So much, Rita, and welcome everyone. We're very excited about today's phone call. As you can see, the objectives are we want you all to understand the current evidence that supports the use of SMBP to improve maternal health outcomes. We are counting on a robust discussion regarding the gaps and challenges to widespread SMBP use in this space. But more importantly, we really are looking forward to you all and our panelists sharing some of the solutions that are emerging to make good use of SMBP in the maternal space. Next slide. And I'm pleased to introduce our featured presenters. You'll first hear from Hillary Wall, who is the Million Hearts resident expert on SMBP, the division's resident expert on SMBP, and I guess CDC's resident expert on SMBP. And then Kamala Phillips, who is a obstetrician and founder of Kala's Women's Heart. She'll be talking about her experience using and promoting SMBP to help her patients in New York. And then we'll hear from Lisa Green, who's a primary care clinician and founder of the Family Christian Health Center, talking about what she did to gather the right expertise around the table to open a maternal child health center. And then we have a whole slew of panelists that Meg will introduce as we get closer to a discussion point. But with that, let me turn it over to Hillary.
Great. Thanks so much, Judy. And good afternoon, everyone. It is truly my pleasure to be with you all today. And I am, as Judy alluded to, a huge supporter of widespread SMBP implementation. And today I'm going to give a high-level overview of the role it could play to address hypertensive disorders of pregnancy and really talk through some related considerations that I think are important for us all. Next slide. So I think it's just really important to take a moment to acknowledge the fact that most of the slides I'll be walking you through were developed from published literature that studied women. So I'll likely be referring to pregnant women throughout, but I want to acknowledge how important hypertension and related cardiovascular risk is among transgender, intersex, and non-binary people as well. Next slide. So as you likely know, Million Hearts has always had a focus on blood pressure control as a major way that we can prevent acute cardiovascular events. For our 2027 platform, which we launched this year, we've added a special focus on addressing equity issues for pregnant and postpartum women with hypertension. Next slide. So let's just level set for a second. When we use the phrase hypertensive disorders of pregnancy, we're referring to a spectrum of conditions that includes chronic hypertension, which is when a woman enters pregnancy with hypertension or develops it early on in her pregnancy, gestational hypertension, which is developed after 20 weeks of pregnancy, and then more serious conditions, including preeclampsia and eclampsia. And when we look at surveillance data, we see that the prevalence of these conditions is actually increasing over time. And there may be multiple contributors to that, including increasing prevalence of obesity and diabetes, as well as increasing trends that we see in maternal age. I think it's also really important to note that we see tremendous disparities and inequities in the morbidity and mortality of hypertensive disorders of pregnancy, with Black and American Indian and Alaska Native women experiencing a greater burden compared to white women, which may stem from things like racial bias in the U.S. healthcare system throughout the continuum of pregnancy. Next slide. So as of 2019, the overall prevalence of hypertensive disorders of pregnancy was about 16% in women who have hospital deliveries. That's 1 out of every 7 births. For women who experience these conditions, there may be many potential adverse effects, right? For mothers and fetuses, there can be acute cardiovascular or pregnancy-related impacts such as stillbirth or preterm delivery. And hypertensive disorders can negatively affect the longer-term cardiovascular health of both mothers and their offspring. So it's really important to attend to these issues. Next slide. Now, as you all know, we talk about this a lot if you've joined this forum before. The evidence for the use of self-measured blood pressure monitoring in general populations with hypertension is strong. We know that it lowers blood pressure and improves blood pressure control. It can improve medication adherence, reduce clinical inertia, and other outcomes. But there have been fewer studies specifically related to SMBP in pregnant populations, and frankly, there's a great deal of heterogeneity or variability in the published studies with regard to a number of different study characteristics. The bottom line is we need more studies before we can truly quantify the impact that SMBP has on pregnant women. But that being said, it really is a do no harm strategy that can provide, at a minimum, helpful insights to both patients and clinicians during pregnancy. Next slide. So in September of this year, we published an article in the Journal of Women's Health that highlights some considerations to address when using SMBP in women during pregnancy, but beyond that as well. So let's talk through a few of those issues right now. Next slide. If you've ever attended these SMBP forum calls in the past, you have most certainly heard us mention the US Validated Device Listing, or VDL, quite a bit. This is where we normally point folks to who are looking for SMBP devices that have been clinically validated. And there are other sources out there. Stride BP is another good one, but in the US, the Validated Device Listing is what's been stood up. Now, during pregnancy, we all know that women's bodies undergo physiologic changes, including the fact that their blood volume increases significantly, which can have an impact on blood pressure. So it's very important to try to use SMBP devices that have been validated specifically in pregnant populations, but those are harder to find than they should be. So right now, the VDL does not currently denote whether a device has been validated in pregnant populations, but I do anticipate that changing in the near future. In the meantime, Ghazi and Bello published a great article last year that includes a table of home blood pressure devices that have been validated in pregnant populations as found in the published literature. And we are very fortunate to have Dr. Natalie Bello on our call today, and she'll be part of our discussion panel in just a bit. But I did a little cross-checking between Dr. Bello's article and the VDL. And if somebody will click once, you can see, next slide. You can see that there are two devices that are currently on the VDL that are also in Dr. Bello's article. So I think this is a great starting point. We've got some nice cross-checking between two great sources, but we're going to get there, and I'm hopeful that there's going to be lots of good progress in this area of denoting validated devices for pregnant populations very soon. Next slide. Now, in addition to using devices that are clinically validated, we want to be sure that women are using the correct cuff size. Using a smaller than recommended cuff size could result in higher blood pressure readings, on average of about 5 millimeters of mercury. And earlier this year, we published an article using data from the National Health and Nutrition Examination Survey, or NHANES. And there, you may recall, there are surveys and actual physical measurements. And so arm circumference is one of those measurements. So we looked at, what do arm circumferences look like in people in the US? 1/3 of women of reproductive age, here defined as 20 to 39 years of age, 1/3 of those women needed a large or extra large cuff based on arm circumference. And when you looked at that same group that had hypertension, over half needed a large or extra large cuff. Now, some of these women of reproductive age may become pregnant. And so this is why I'm bringing this up, right? Pregnancy-related weight gain, as we all know, is appropriate. But data show us that almost half of women gain more than the recommended amount for their particular body mass index. So my question is, what impact could that have on arm circumferences? And as a result, should we recommend that arm circumference be reassessed during pregnancy, especially if a woman is on the cusp of a given cuff size when she's recommended SMBP? So, if SMBP gets recommended at the beginning of pregnancy, should we recommend that it get reassessed later on in the pregnancy to make sure that that cuff size is still accurate for that woman? So these are just some important considerations from a blood pressure accuracy standpoint. Next slide. So these next two slides are what I am referring to as SMBP adjacent, if you will. Using SMBP to improve blood pressure control is really a moot strategy if patients with hypertensive disorders of pregnancy are not being diagnosed and managed. And some OBGYN practices may use registries or other electronic health record features to identify pregnant women who are eligible for SMBP, for example. If they're using an ICD-10 diagnosis code to do that, to find those women who they want to get, started with SMBP, they may actually be missing some people. So let's walk through what I mean by that. On this slide, Kaiser Permanente did a retrospective analysis of 570,000 live births in 3 states where they used a broad case definition of hypertension that included diagnosis codes, the 2 that you see highlighted in yellow, or if a woman had 2 or more elevated blood pressure readings in absence of a diagnosis code. So those are our 2 groups, diagnosis code or 2 or more elevated readings. And those elevated readings you see in green on the slide. And if you go to the next slide, when they looked at this broad case definition for hypertension, they found that 72% of women received a diagnosis for hypertension, but that means that 28% of women did not receive a diagnosis. And 20% of those who did not receive a diagnosis had 1 or more severe blood pressure values of greater than or equal to 160 over 110. And that blood pressure, that severe blood pressure, that indicates somebody who should be treated, at least during the guidelines that were in place during this time period. So the real take-home message here, and I've done some math as I read this paper, is that of those with a diagnosis code and that severe hypertension value, severe blood pressure value, 87% received treatment for severe blood pressure versus only 38% of those with no diagnosis code. So often diagnosis code equals treatment. Here it's antihypertensive medications, but I think that's also very applicable to SMBP as well. So next slide. We're going to take questions in a bit, but please always feel free to email me at any time. Thank you.
And next we have Dr. Camila Phillips.
Hi, good morning or afternoon, everyone. I just want to make sure you can hear me one final time. All good?
You sound great.
So thank you so much for this opportunity. This is a experience of a lifetime, and for me, that is being able to bring these babies into the world to healthy mothers, healthy families. And I'm going to spend my 10 minutes very briefly just talking about how I do that in a reproductive health setting that is often busy. We are overwhelmed, but want to also encourage you to do your best to incorporate SMBP into your practice because it can be done. This is a patient that I just wanted to share briefly who I, in my 15-year career, have never lost a mother. And she was a mother that I actually lost about a month and a half ago. And I literally mean I stopped taking track of her codes when we got to 10. So this is real life stuff. We are really saving women and saving families' lives by doing this very straightforward and simple intervention. Next slide. So I really want to break this up into how I do it in my office. It starts with education, well, assessment, first of all, then education, and then the actual intervention. And so starting really early and simply is to cast your net very broadly and identifying people, as we heard about before, who could potentially be at risk. This includes ethnicity, history of kidney disease, diabetes, hypertension in previous pregnancy. And this takes some time to really probe women to make sure that they're remembering their pregnancies, past history, family history, but can be done very concisely to cast a broad net as to everyone who should be assessed and considered for this intervention. I practice in New York City, which is a very complex population. And so I have to say, almost everyone who comes in for pregnancy does fall into this category, which is fine by me because I would rather cast my net very broadly and then narrow the interventions for people who need them. So after we do our initial assessment, which is on paper, patients do that, and then we review it with them, any risk factor, I don't use multiple, but really any risk factor is a trigger for not only a high-risk medicine doctor consultation, but also a cardiology assessment. Next slide. And from here, we start with education. I really want to set the expectation for my families that they are going to have a healthy pregnancy. They are surrounded by a team of doctors and nurses who are going to get to know them, understand their concerns, communicate with them. And the real expectation is they're going to have a healthy pregnancy. I encourage them to bring a companion to every visit, and this helps me in a number of ways. It really helps to spread the education throughout the family as to how we are all joining together as a team to focus on this patient, this pregnancy, so that we can have healthy expectations. It also helps. For the patient to have an informed and involved advocate with them. I don't necessarily expect the same person to come every time, but often we mix it up. So I'm meeting the family who's, the patient's primary care team. And in that process, I'm educating both family and patient as we go through this 10-month journey about what we should be looking for to achieve our maximal health. It also serves as an accountability partner for the times when I am not there and the patient either decides not to take a blood pressure, maybe doesn't make the best decisions around diet or exercise. That person that comes to their visit as a companion is also their accountability partner. The next thing is we use very plain language here. I think every time we talk to someone, we can talk over our patients' heads, obviously. We use plain language and we use this to help empower them in the conversation with them. As we move through the pregnancy, we do get more sophisticated, which improves health literacy in the community, but really ensures we have effective communication. And then finally, everyone gets homework at the end of the visit, and that's either blood pressure, um, ranges that we're going to check in and work on, weight management expectations. I am very strict as it relates to weight because we know that is a risk factor for not only hypertension, but diabetes, C-section, et cetera. And then finally, an activity plan that everyone goes home with. Next slide. I'm not going to go over this too much because we talked about it, but in the expectations for health, I often don't want to spring on them at the end of pregnancy that they may have to have an induction so that we can prevent some of the complications that we know are associated with hypertension. So we start talking about delivery really early on so that it's not a surprise. And we usually start talking about inductions in the second trimester with the plan and a date for somewhere in the third trimester. The blood pressure instruction is super important. I won't belabor that, but the impact on the correct cuff size in a validated machine cannot be underestimated. You'll find that most patients are not using the right cuff size, and really explaining to them the why. Why are we doing this? And when they feel and accept, buy in that they are doing this as part of their healthcare strategy, including information on when, where, and how to do it. It really does work in the small clinical setting. And then we are decidedly low tech. I've moved a little bit away from apps. We use a pen and a paper so that patients can record their blood pressure readings. They send it to the office regularly, and it really has worked seamlessly. Next slide. And finally, I just want to talk about the interventions that I use. I have a healthcare team, that I've been able to build around me. And the coordination of care really does start early. This is primarily with cardiology. We have this field of obstetric cardiology that I don't think enough obstetricians, primary care, family medicine that we use enough. And so cardiology is really important. They see our patients early. Many of them receive echoes, EKG, and aggressive blood pressure management with me throughout the pregnancy. I incorporate maternal fetal medicine into all of my patients' visits so that they're hearing continued messaging, all the same messaging as to why we're doing blood pressures, why we're starting medication, the importance and safety of medication. So reiterating those themes to patients over multiple specialties has been very helpful. And then finally, I do use endocrinology and nutrition a lot. You probably realize that most of Americans don't know how to eat and don't understand really the concept of nutrition. So I would say of those two, nutrition has been really helpful for us. And then setting really clear goals when we're doing this intervention, including early and aggressive blood pressure management, using a team approach with the expectation of healthy pregnancies has been invaluable. And this also helps me when it comes to compliance, because I'm sure all of us meet patients who are very skeptical about taking medications in pregnancy. And our aspirin intervention tends to start very early. So as we're doing this education and intervention, they do comply with what we're asking them to do, because we've established that the culture is we are all on the same team for healthy pregnancies. So as it relates to aspirin, nifedipine, labetalol, and labor inductions, we really do have a good system at the end of the day. Next slide. Next slide. And then this is just my final OB wish list, the things in a perfect society if insurance worked for us that I would love to have. Can you, hold on, I can't see that. So one is just better insurance coverage. I don't think that people really understand what their insurance does or does not allow when they get pregnant. And when we run into issues, they're left a little bit short-sighted. So improved insurance coverage for everyone who's reproductive age and of potential. It's really important, and I love when internal medicine, family medicine gets involved and does preconception visits prior to pregnancy, so we can start tuning up these women and their health before they actually enter the reproductive phase would be great. Access to blood pressure cuffs universally, so that I'm not arguing with pharmacists or insurance companies why this intervention is so important. The data is there. Nutrition services and clean food. I live in New York City, but this is absolutely a food desert for many of my patients, which causes high cholesterol, hypertension, morbid obesity. And so nutrition services and clean food and access to that clean food would be something high on our cultural list that I think we should all incorporate. Fitness counselors and gym, I would put that out there. I love seeing women who are in their reproductive age and pregnant working out. And then more routine visiting nurse services postpartum for blood pressure evaluation and newborn care. We need to relieve some of the stress of a newborn on our new mothers and even older mothers, so that they can focus on themselves and their blood pressure. And then evidence-based um, um, science and information that permeates our culture, social media especially, so that people are learning from the data that supports this intervention as being wise and trusted and true would be another thing, as opposed to the TikToks and the other things that often misrepresent what we're trying to do to augment women's health. So I'll stop there. Thank you so much, and I look forward to your questions.
And Dr. Green, I welcome you to get started with your presentation.
Sure, I will. You can actually go to the next slide. Um, Good afternoon. My name is Dr. Lisa Green, and I am the CEO and one of the co-founders of Family Christian Health Center, an FQHC that is located in the Southland of Chicago. And I'll start by saying that in the onset of COVID, I became aware of just some of the national and the state data. And here in Illinois, we realized what the data showed that Black women were 6 times higher to die than their counterparts, white and Latino population, and that the hypertension rate was higher. And after we realized just some of the devastation of this data, we pulled together a forum because I was like, well, what are we doing? Right? I know there were different meetings and there are different committees, but how do we really get to the grassroots of this? So we put a forum together, and it was called Breaking Silos and Taking Action. As a result of that, we had representation from 8 of the hospitals in our area. We'd had representations from the medical schools. We had representation from the state legislation, from communities, from just community partners that all came out. And it was one of the first times that everybody came under one umbrella to discuss Black maternal health. After that, we had a follow-up Facebook Live, which occurred in the middle of COVID. And part of the reason for the Facebook Live that we did was because we realized in areas where they were already at high risk, 2 hospitals had closed their doors for maternal deliveries. And part of that Facebook Live conversation was just how as simple as having access to a blood pressure cuff could change lives. Fast forward, what ended up happening after viewing of the information, it spread news to our state, and our state legislators and insurance plans heard that cry. And now every woman that is pregnant, regardless of whether they have blood pressure or not, receives a blood pressure cuff in the state of Illinois. And we were extremely excited about that as a tool to help us really be able to help our patients. But then we went a step further, as opposed to just the blood pressure cuff. If you go to the next slide, please. We began to map out, how do we begin to take the blood pressure, all the other social determinants of health, and look at all these barriers, and what can we do ourselves as a clinic that we think that we could do our part in moving the needle in maternal health. And as a result of that, if you go to the next slide, we actually opened up the first of its kind, and it's called Family Christian Health Center Maternal Health and Wellness Center. Some of the barriers that our women face are not just living in food deserts, but transportation is a major issue. So many of our, patients, as a colleague mentioned earlier, are high risk. So they require the use of MFM. And what's a 10-minute car ride is an hour and a half each way in transportation for us. So we created a center where women could come and receive comprehensive care. We made it aesthetically nice so that it would be warm and inviting. We may not be able to change the zip codes that they currently live in, but what we could do is bring them the best of what there was to offer in quality health care. So in that facility is a waterfall, there's a Keurig, there is the ability to talk to a mental health provider that's there. Our case managers are there. And we have a MFM that actually comes. We did a partnership with our local hospital. And instead of having to send our patients out to MFM comes on site. That increases the trust component, because so many of these women, besides the other issues that they have to deal with, the social determinants of health, it's also become a big trust issue. And so this environment really has lent itself to a trust within the community for women to understand that they're valued and that we are invested in their health, and that we really need and want to partner with them to make sure that they have great outcomes for them and their baby. We understand that they can't make it to an appointment because they don't have a babysitter, or they need a referral to go one place and they can't get in. And so we try to bring all those services there. When you look at the timeline that we created, we were able to open up the center, and within that framework, the MAP-BP was extremely important for us. We worked with our nurse practitioner students, we worked with our medical students, and we worked with our MAs. We realized workforce development, everybody is tired. Everybody has, these different issues that we're trying to take care of. But we really had to get the first was the buy-in of the staff, because our medical assistants became a big voice for us in talking to our patients, to ensure that everybody got a blood pressure cuff, that they knew how to take their blood pressure at home, and whether they recorded that by writing it down, by putting it in their phone. And then it was followed up with phone calls from our community health workers and our staff. If you can go to the next slide. As a result of embarking on this, we were actually able to decrease our blood pressure rate by about 10%. We were also able to change some of the ratios when we looked at maternal death. Another caveat that for us that we found important when we rolled out blood pressure is that they understood the importance of food, and telling someone to eat healthy and really understanding what their options are, whether it's location or cost, are different, right? And they have to understand that. But at the same time, you have to give them some options. So we partnered this program also with women were able to get groceries once a week. We had a farmer's market that was on site, but for those women who could not get out, we were actually able to have groceries delivered to them with recipes that showed them how you can still make, greens, but maybe not use smoked meat, and how you're able to eat some of the same foods that you would normally eat. But let us show you some ways that will help you and your baby. And so by giving these women the blood pressure cuff, by giving them access to food, by giving them the education, it really, really helped us drive the needle. On top of that, we were able to open a centering program. And within that centering program, that's an opportunity where our providers can then reinforce with women the importance of their blood pressure, helping them understand what hypertension is, helping them understand the choices that they make. Again, a lot of times we know stress is a huge factor, and that factor can be based on many modalities depending upon the zip code that you live in. And so our goal, again, was to really be able to equip them with what they needed to make wise choices. The program over the last year and our opening, we actually did 500 new OB intakes. I think it's 551 new OB intakes, and 400 of them were done in the first trimester. The program was able to offer women not just the education, but also the tools, again, to equip them, and then the staff really understanding how important it was that even if the providers were busy, then wait a minute, how do you, we need you to help remind us that it's important to ask the women, are they using the blood pressure cuff at home? Is there some more information that they need? One issue that we did encounter is size, as was mentioned earlier, does make a difference. So for those women who had a blood pressure cuff that didn't fit, we were able to alternate that and help them get the one that they actually needed. Next slide, please. So I want to end by saying this is an initiative that I am so grateful for the opportunity to be able to present with you guys today, because we are all in this together. I always say I am my brother's keeper, right? So, but I like the idea so much that we have a platform that NAC provides for us to be able to, how do we bridge and learn from one another? How do we take the tools that we've been able to use in our communities and maybe pivot them into the areas that we're able to then make a difference in our communities? I think that when we look at the changes that we were able to make here, it started with a combination of putting the patient first, also talking to our legislators, talking to our hospital partners, talking to our MAs, talking to our patients to find out what would make things better for them. We do needs assessments in most of our organizations, but I think really taking that and drilling it down into maternal child health to help really be able to drive the needle of care. And as a result of that, what we found is that it created a level of trust that we have to earn in our communities, but at the same time, ensure that care can no longer be driven by the zip code that you live in. It has to have the same quality regardless of the zip code that you live in, to ensure that every mom and every baby has access to quality health care. So I thank you for your time.
Thank you so much, everyone. Such great insight in terms of how to get the family involved and community resources that are beneficial to mom and baby and family. I'm going to turn it over to Meg Metter of NAC. She's going to be our moderator for the Q&A discussion. So Meg, the floor is yours.
Thank you, everybody. As Rita said, I'm Meg Metter, Director of Clinical Integration and Education with the National Association of Community Health Centers. And I have the pleasure and honor of being here today with you and moderating our Q&A discussion. Next slide. So as you can see here, in addition to Hillary Wall and Doctors Phillips and Green, from whom we just heard, we have a whole host of other experts in the area of hypertension and maternal health who will be looking to contribute to our discussion today. And these include Dr. Evelina Graver from Northwell Health, Eleni Sigas from the Preeclampsia Foundation, Dr. Colleen Harrington, who practices at Mass General and serves as governor of the Massachusetts chapter of the American College of Cardiology, Dr. Natalie Bello from Cedars-Sinai, who Hillary referenced earlier, Fatmata Williams from Connecticut Medicaid, Bernadette Dalmeda from the Community Health Network of Connecticut, and Aisha Saida from the American Heart Association. So thank you to all of you for your willingness to participate with us today and lend your expertise and time to our conversation. I just want to say, I'd planned to answer a couple of questions from the chat today. It's been hugely robust. We've had conversations about cuff sizes. We've had conversations about using text messaging and social media and including that companion person that Dr. Phillips mentioned as being so important to be an accountability partner. I don't really have questions, but I just want to recap some of my favorite things that were just mentioned. In Dr. Phillips' presentation, I love the concept of erring on casting a wider net to avoid missing any women who might have pregnancy disorder of hypertension. I love that concept. Dr. Green, I loved the education tools and staff supporting women with SMBP as sort of this holistic approach that creates trust and fosters health equity. So thanks to both of you. Really appreciate it. I actually am going to move to the discussion questions at this time, and want to first pose a question to the clinicians on the panel. All of you don't have to answer, just feel free to answer if you feel like it. But this question number one here is, when caring for pregnant or postpartum women using SMBP, what are some of the best practices and solutions that have worked well for your organization?
So Meg, hi, how are you? It's Evelina Graver from Northwell. If I can just take that on. First of all, I love every single one of the presentations, and just to mention, Dr. Phillips, your concept of the cardio obstetrics team has been a very robust component here for us at Northwell, and has worked significantly. So you're definitely on the right track when it comes to that. So I think that one of the best things that sort of has been working here for us at Northwell and for the recently opened Center for Maternal Health is really kind of using logic behind all of it and understanding what are some of the potential obstacles that we may actually run into. And one of the biggest obstacles that we ran into, and I believe we've kind of mentioned it, is sort of our ability for some of these pregnant women or even postpartum women to actually get that appropriate access, whether or not it's into healthcare or actually access to the device itself, right? So the way that we have done it and helped out a lot of women that have either, child issues or anything else is opening up the world of telehealth for them. And that has made a significant change for them, because they're able to sit in front of the computer, show us exactly how they actually are taking the blood pressure, making sure the fact that we actually are providing the appropriate education for them while they're taking their blood pressure. And they don't have to feel at all rushed to get into the hospital to see the doctor. They don't have to feel rushed as to potentially getting that appropriate childcare for their other children, if need be. And having that ability to work with us as a full team. And I think that that's one of the most important things that I myself, as a physician, have learned, and as a cardiologist, is the fact that we no longer are able to practice in these sort of tunneled vision silos, right? I think that in order for us to truly help a lot of these women and to truly make a benchmark change when it comes to maternal health, we have to work as teams and collaborations.
Excellent, thank you. Anyone else?
I'd love to chime in. I completely agree. I think the talks were amazing, so inspirational, and thank you for including me today. I would also stress the importance of education for the patients, that really start at preconception if we get that opportunity. I think all of us on this call realize we don't get that. As far as those dietary interventions starting before they get pregnant, and physical activity, which we've shown that actually can reduce gestational hypertension by 30% and preeclampsia by 40%. So it's identifying those women at risk and then teaching them why it's important to check their blood pressure and what's the correct way to check their blood pressure. Most people, pregnant or non-pregnant, don't even check their blood pressure in the correct format. And finally, I would say the postpartum period is often forgotten. And we, as a mother myself, we all get very busy in that postpartum period of just trying to get a sense of a new world. And postpartum hypertension, as we all know on the call, is a real thing. The number one cause of maternal death in the postpartum period is hypertension, with anywhere from 8% of women who don't have hypertension during pregnancy develop it in the postpartum, and up to 50% of patients with preeclampsia will develop postpartum hypertension. So it's educating those patients that the blood pressure monitoring doesn't stop once the baby comes out. I know we're all busy. And then what I've worked really well for me is not only those educational aspects, but follow-up. As mentioned, telemedicine, if it's really hard as a new mom to get there, patient electronic records, send me messages, check in, and then I will get back to you and then either make a phone call, televisit, and if possible to come in, if that's possible with the childcare and the obstacles of being a new mom. So I would just focus on education at ideally preconception, every single visit, every single patient message. It's reiterating the importance and why it's important. Has worked really well for me with that close follow-up and not forgetting about that postpartum period, which is a vulnerable period, but also a period that we can actually make a significant impact, not only on maternal readmission, which is the #1 cause, but maternal mortality. So a few things that have worked very well for me at Mass General.
So I love this. I really appreciate it. So we've talked about focusing on access, addressing social determinants of health, the importance of education on lifestyle and why monitoring your blood pressure is important, the technique, and then of course follow-up and outreach. And it's interesting, you know, SMBP alone is not an evidence-based strategy. It's evidence-based when it's with clinical supports. And what you're describing are all those really critical supports that have to be in place to make it really work. So appreciate that. If there are any other additions to this question from our other clinicians, would love to hear it if you have a different angle on this one.
Yes, hi, this is Fatmata Williams, and I just wanted to first of all thank all the presenters. It's been very informative, and I do agree with all of the above and what's been said. SMBP alone is not going to improve outcomes for people. The clinical supports and the social supports are really vital in ensuring improved outcomes. I wanted to talk a little bit from Connecticut Medicaid's perspective. We're a health plan. So what we did right from the beginning for people, pregnant people, and all the way to the postpartum period was to have the ICD-10 code of pregnancy as one of the criterion for people to get the blood pressure monitor. So we took away that access issue where we are not waiting for them to develop hypertension before we give them access to the blood pressure monitors. And then the other thing we did was we are fortunate because of our model of services delivery where we use an administrative services organization model where we carry all of our own clinical and financial risks. So it behooves us to really care and focus on improving outcomes for our members. So we focus a lot on prevention. So we have access to an integrated set of data. We're able to look at our data, see you know, the health of our members, see the people with hypertension, look at people within the reproductive age, target them, education around, you know, obesity, healthy foods. If you're trying to get pregnant, some of the things that you need to do. We provide that education for people who are pregnant. We also have programs where if it's an average risk pregnancy, we have wraparound supports, helping them to make sure they're making their doctor's appointments, helping them to make sure that they're following their care plans. They can access the portals. Those who are willing can access the portal. Those who are able. Those who are not able can get telephone calls. So there's a lot of wraparound supports for pregnant people, preconception, pregnancy, all the way to postpartum. So I do believe that the education on that front, as well as educating the providers, some of the providers are not aware that blood pressure monitors is a benefit. So we also reached out to providers, educated them, provide reports about their patients so that way they're aware that them prescribing a blood pressure monitor is not going to be a problem because it is a coverage. So I think it takes like a multi-pronged approach, including all of the social supports to continue to improve outcomes for the pregnant and postpartum population.
Fatmata, thank you so much. And I love the fact that you're educating clinicians about, you know, what's available, what they can access, and of course, wraparound services. I'm going to move. We now have a great sort of comments in the chat that I think can be flipped to a question. So this is from Odele Ogani, and she says, it's challenging to get postpartum women to do SMBP as they're dealing with many competing priorities, taking care of a new baby, other children, family obligations. Any tips for effective SMBP in postpartum women?
I'll jump in on this
Hi.
one.
Okay.
Sorry.
Go ahead, Natalie.
Great,
And then
thanks, Natalie.
I'll be quick and then pass it over. I think one of the things that we do, and it sort of builds on, I love what Dr. Phillips was saying about the idea of giving her patients homework. When we have the benefit of having interactions with our pregnant patients during their pregnancy and teaching them about the importance of SMBP and blood pressure measurements, it's actually, once they understand the importance and why we're interested in this, it's not as much of a burden or sort of an extra thing in their lives. They understand why it's actually going to keep them hopefully at home with their family, out of the hospital again, prevent problems for them, keep them with their newborn baby, not get separated and have to go to the emergency room, because, as has been said, we can use telehealth interventions to increase their medications at home without having to see them. Obviously, if someone develops worrisome symptoms for postpartum preeclampsia, we bring them in. But in many, many cases, we can use education during the pregnancy and even during the delivery hospitalization. We're working with our pharmacy to stock devices so that if people don't have one and they're considered high risk, we can actually send them home with a device, so that way that's not another impediment to them being able to measure their blood pressure.
Excellent. Thank you so much. Go ahead.
Yeah, this is Eleni. I'm actually, Natalie said exactly what I was going to say, but I want to add another layer to what essentially everyone is talking about. And Camila talked about this in her presentation, which I loved, which was all around expectation setting. And not only does doing that throughout the pregnancy lend itself to less confusion around the time of delivery and more adherence with SMBP in the postpartum period and everything that everyone's talking about. But there's also a huge mental health component to this, because one of the things that we hear at the Preeclampsia Foundation over and over again, one of the leading contributors to the emotional burden of a preeclampsia diagnosis is, I had no idea. This came totally out of the blue. And it's the delta between expectation and reality that we see over and over again contributes to the hardest emotional burden of having this kind of an adverse pregnancy outcome. So the more talk that happens ahead of time during the pregnancy, expectation setting, this isn't necessarily going to happen, but this is what might happen. This is the importance of doing these things. All of that conversation that happens during pregnancy is not only going to help with postpartum care and management and health, but emotionally is going to make a huge difference for the mother and her family.
I love that, Eleni, that expectation setting and sort of starting the conversation early. I want to just quickly say that Dr. Phillips actually went back to what she brought up in her presentation, which is, having that family member or companion being the one that's assigned the blood pressure monitoring, so that the healing woman doesn't have to have another thing or another task on her plate. So I do want to move to the second question. I want to start with Hillary Wall on this question, and then would love to hear from some of the panelists we haven't yet had a chance to hear from, maybe Aisha. So the question is, nationally, what can be done to support and enhance the implementation of SMBP for pregnant and postpartum women? Hillary?
Thanks, Meg. Yeah, I'm going to chime in at a really high level. As we all know, the old adage that says what gets measured gets done. And in Million Hearts, we've really leveraged the power of clinical quality measures to help drive quality improvement in the country. And Rita, I know I asked you to hide a slide, but maybe you could pull up that slide. So this right now, if we look in programs, quality reporting programs like CMS's merit-based incentive payment system, there are clinical quality measures in there, and there's a group of measures for OBGYNs. There's a specialty measure group for them, and they include these two measures that you see on the screen. The one on the right is the one that many of us know about, CMS 165 or NQF 18. This looks like blood pressure control in the general population, but it excludes pregnant women. And then the other measure in yellow on the left, CMS 22, looks at screening for high blood pressure and then a follow-up documented. And this includes pregnant women, which is great, right? We love this. But I think there's maybe a measurement gap here that at a national level, we might work with partners to try to address, where really, Dr. Phillips said that it's important for early and aggressive blood pressure treatment. And how do we encourage that through clinical quality measures. It's not the silver bullet, but I think it's one piece of the pie to help move forward hypertension control in this population and support better SMBP use.
Appreciate it so much, Hillary. I think we have time for one more response for question 2.
Hi, this is Connecticut, and maybe what we'd like to do is I am a colleague of Fatmata's, and I actually work as part of with the medical ASO. And I think nationally what Connecticut has done is, one, expanded coverage, but also to foster that usage of SMBP is Connecticut has done an obstetrical pay for performance. It's an opt-in program for our OB providers, and we added the measure around self-monitoring of blood pressure along with aspirin to facilitate appropriate use, continual use, and then that allows us to identify providers, engage with providers. It also trickles down to members, and if a member is struggling or is coming up as high risk, we offer intensive care management support to address and help them find value in that blood pressure monitoring and continuing to do so.
Thank you, Fatma. I think it's just so true. You and Hillary both, made the statement, made the point. We do what we measure, right? We tend to what's measured. So such an important lever nationally to get right. So I think I want to just make a quick correction. I did say American Heart Association for Aisha Saida. I meant Hospital Association. My husband would be mad at me because he's a hospital person. Do you have any final words that you want to add? Not to put you on the spot, but I felt like we didn't give you time.
No, I think this has been a wonderful conversation. So thank you for inviting me and for allowing me to share the space with such great experts. And yeah, I would just want to add that besides having those quality measures is also having a standardized screening protocol within hospitals. So we are aware of when something like hypertension can come up in the trajectory of a pregnant woman's journey or a postpartum woman's journey. So having those guidelines and having those protocols set. And then another thing would be just having those community partnerships, having people outside of clinical walls to kind of set that referral system as well. So those were the 2 points that I would want to make.
Excellent additions. Thank you so much to all of our panelists. Really appreciate all of the conversation and insights. And I'm going to turn it back to Rita for updates.
Great. Thank you so much, Meg. I'm going to go in and get started with our updates. First, we have Brittany Royal. She's with NIH, and she'll be providing some NHLBI resources. Brittany?
Thank you. Again, my name is Brittany Royal, and I'd like to thank you for having us. I'm one of the program managers for the Heart Truth, and we would like to share several of our resources that we have to help support SMBP efforts and tips to accurately measuring your blood pressure. So right here we have a few fact sheets, one being the high blood pressure and women's fact sheet, questions to ask about your blood pressure to your healthcare provider, and pregnancy and your heart. We also have several other fact sheets that focus on general high blood pressure, resources to help you track your blood pressure readings, and dietary approaches to stop hypertension, better known as DASH, eating plan, fact sheets, and resources. All these resources are available for download. Many of them are available to order print copies for free, and you can also find them in English and Spanish, many of them. Next slide, please. We also have several social media resources. We have graphics, GIFs, and social media content that you can share on your social media platforms. Here we're sharing a few that focus on high blood pressure in women, including women who are higher at risk for high blood pressure, tips to accurately measure your BP, and our GIF featuring our heart character. We also have other social media resources that focus on pregnancy and high blood pressure, as well as our Heart Healthy Pregnancy Registry. At the bottom there is a GIF that encourages you to practice self-care for your heart and control your blood pressure before, during, and after pregnancy. Next slide, please. So all of these resources can be found at nhlbi.nih.gov/hypertension. And if you have any questions for the Heart Truth team, you can reach us at healthed@nhlbi.nih.gov. And we've also listed our social media handles, so we would love for you to follow us as well. Thank you.
Wonderful. And next we have Eleni from the Preeclampsia Foundation. You're back up to present your slides.
Thank you. So the main thing that we're doing on SMBP is the Cuff Kit project. And at this point, we have actually distributed over 16,000 cuff kits to via 191 providers in 21 states. And the beauty of it is not only that it clearly demonstrates high interest in SMBP amongst pregnant patients, pregnant and postpartum patients, but it's allowed us to collect data and to start building out the evidence base. While certainly it exists, and some of the presenters on this talk have demonstrated some of that, there is more data that's needed to demonstrate the efficacy and cost effectiveness. Some of the things on this slide we've already talked about, but I'll just say that the Cuff Kit program does use validated in pregnancy devices. We used to use an Omron device, but the large cuff size was not available, so we switched over. We're using iHealth now. The picture that you see here has all the components of the kit, which not only includes the device, but the logs. And we do, I heard someone mention like analog, paper logs. We do offer the paper logs and we demonstrate how to use them. We also offer an app version for those who want to be a little bit more high tech about it. And we're also working with Epic to get it into to get the data directly ported into Epic systems. I think the key to the kit is not just that we're working with a validated device and appropriate cuff sizes, but that it really comes with a package of patient education material that's been optimized for this population and covers everything from how to take your blood pressure correctly. And it presents it with video, with online information, with paper information in Spanish, in English, actually some other languages as well. And so that whole package of care goes beautifully with what everyone has talked about today, in that this is not going to be the panacea by itself. It has to be integrated with a clinical approach. We also offer technical assistance meetings through our monthly Cuff Kit Connection sessions. We do, as I said, collect data on this, and so doing data sharing is important because we want you to understand how this is impacting your local as well as larger populations. And we are taking care of all fulfillment and distribution of the kits directly to any sites in the state or U.S. territories. So more information can be found on the link that I have there or the QR code, or you are welcome to email us.
And Janet, you're up. I know you are very quick and efficient, and we appreciate your time to share the next federal plans to address maternal health.
Thank you so much. Can you hear me?
Yes.
Wonderful. I will go quickly, but I do want to say I have been increasingly hopeful and optimistic about the ability of all of us to contribute to a turnaround in maternal health. But today's presentations have made me confident that that is the case. So quickly, I will just say, I want to show you the evidence that the federal agencies are also committed to the goal of improving maternal health. On the slide, you see 3 documents issued over the last 2 years. These have input from across the entire Department of Health and Human Services, and in fact, across all of federal government. Next slide shows just a subset of federal initiatives specifically addressing blood pressure control in women. This is a subset. I'm so glad to hear Brittany's presentation from NIH. Indian Health Service is also quite active, but I think this is just a chance to show you a taste of locking arms with the private sector that we've heard from today. So that we together can help bring women's blood pressure under control. Next slide. Excuse me. I think that many of you have heard about CDC's Hear Her campaign. There are resources listed on this slide. Sorry. The heart of this campaign is to encourage clinicians family members and others to listen to women's symptoms and to take them seriously. I think with that, I'll turn it back over to you, Laura.
Not a problem. So we have 2 upcoming events we want you to learn more about. We have a Million Hearts Climate Change and Cardiovascular Disease Collaborative. That link will be pasted into the chat, as well as the Million Hearts Learning Lab. The January session will be on motivational interviewing and medication adherence. So please check out these 2 upcoming events. If you have time and you're here, please put into the chat any remaining questions you have from today's conversations or suggestions for future topics. We always want to hear from you. We want to hear your ideas and thoughts, and you can send those to millionhearts.smbp@nac.org. So if you have remaining questions or future ideas, please send that to us. And to close, we have our post-call survey. We'd love to hear from you. You can use this QR code as well to register for the next SMBP forum. And also the registration link we paste into the chat. The next one will be on March 9th, 2023, where we will continue the conversation on how we can expand and implement SMBP in various communities and environments and patients across the country. We look forward to hearing from you and getting speaker ideas. And with that, we wish you a happy holidays and happy new year. And we'll speak to you guys again in March. Thank you.